Welcome to Psych Talk for primary care providers, where our esteemed faculty members will provide you with invaluable insights to seamlessly integrate into your daily practice. Dr. Colin Smith is our guest today. He teaches us about second-generation antipsychotics.
Hi, I'm Colin Smith. I'm an internist and psychiatrist and one of the faculty in the primary care psychiatry fellowship. I'm going to give a brief lecture focusing on the monitoring of an individual who's on a second-generation antipsychotic. Second-generation antipsychotics are also known as atypical antipsychotics, and that name primarily comes from the fact that they were developed after first-generation antipsychotics, which are also known as typical antipsychotics. One of the challenges with prescribing an atypical antipsychotic is that there are risks of developing hypertension, weight gain, obesity, and hyperglycemia and insulin resistance, essentially or eventually potentially leading to diabetes. One of the benefits of using atypical antipsychotics, in contrast to typical antipsychotics, is that they potentially have lower risks of motor symptoms or extrapyramidal symptoms, and potentially lower risk of tardive dyskinesia. Because atypicals have been more commonly used, not just in the specialty psychiatry setting, but also in primary care practice, and because they're used to treat psychotic disorders, potentially depressive and bipolar-related disorders, and other psychiatric conditions, it's important to have a really good understanding of how to monitor an individual who's on a second-generation or atypical antipsychotic. And I think about this as really three classes of monitoring. The first class is to make sure that we are monitoring an individual's vitals. So we want to monitor their vitals, particularly their blood pressure, their pulse, their height, weight, so we can get a BMI at their initial encounter, and then make sure that we have those vitals every 6 to 12 months afterwards. And the reason for this is because we want to be able to detect weight gain, potential development of obesity, hypertension, or potentially even hypotension in the acute setting while patients are on atypicals. The second important class or category of monitoring is actually the physical exam. And so every patient gets a physical exam when they're coming into their appointment, but it's also important to get a baseline abnormal involuntary movement scale for people who are on atypical antipsychotics. And this can allow you to both detect and then track or grade the severity of tardive dyskinesia if it is present. And this should be done at baseline and then every 6 to 12 months. And then the third important category of monitoring is laboratory monitoring. As I mentioned before, patients are at increased risk of weight gain, obesity, hyperglycemia, and potentially diabetes if they're taking atypicals. And so we want to make sure at baseline we have a hemoglobin A1C to potentially detect prediabetes or diabetes, and also a lipid panel to detect hyperlipidemia. We want that not just at baseline, but at 3 months and then annually thereafter. If patients have other risk factors, we may need to get that more frequently. Other potential labs include a CBC to potentially detect leukopenia, which could be associated with atypical antipsychotic use, and in rare cases, agranulocytosis. For individuals who are at increased risk of cardiovascular disease or who are on potentially QTC prolonging medications, we would also consider getting an EKG. Although atypicals do have some unique risks compared to their typical cousins and other medications we use in psychiatry, using those kind of three classes of monitoring can mitigate those risks.